Hey guys, welcome to another series of trainings. We're going to do 3 in a row, all having to do with neuro stuff. We're going to call it Brain Day. This is based on a presentation that I was going to give last month at Pleasant View, but they got called out on a structure fire, and so we're going to record it for them, do it live for them, but then also have it as a resource for the other agencies. So a couple of things with this talk. We're going to break it up into 3 separate videos so that people can watch it if they want the particular topic of stroke, traumatic brain injury, or seizure. I know that some of the other agencies we've covered this previously or recently. Also, we're going to put this up for just general consumption as well, and then I'm also going to tack it all together into one long video so that if somebody wants to watch it all the way through for CE credit or something like that, we can cover that as well. So there's going to be a little bit of gaps in there. There's going to be a little bit of repetition at each transition point for some stuff just for folks who are only watching that single one. And if you guys have any feedback or comments or anything else, my email is there on the cover slide. So first off, quick caveat for those who are not in one of those 3 agencies that I do medical direction for right now. Then this training is intended for agencies only under my medical direction as medical direction. Otherwise, it's strictly informational and educational. So your care of patients needs to conform to your training, local protocols, guidelines, medical direction, and your agency's SOPs and SOGs. But obviously, you're welcome to watch this for educational purposes, and I hope you get something good from it. So our goals throughout today are going to include stroke, traumatic brain injury, and seizure. So let's start off with learning goals for stroke. We want to talk a little bit about the history of stroke care and the history of stroke, discuss similarities and differences between different kinds of stroke. That includes things like ischemic stroke, hemorrhagic stroke, and heat stroke, and then also just understand pre-hospital stroke care. Now, for a scope of practice issue, the cool thing about stroke care is unless patients are so completely obtunded they need advanced airway management, which is fairly rare in stroke, then all of the stroke care really falls under BLS protocols, which is pretty cool. And that's true of the other stuff that we're going to talk about today. So obviously the history of stroke, everything, if we want to talk about history of stroke, we're going to go back in time to Hippocrates. Certainly Hippocrates talked about stroke, but obviously didn't know the pathophysiology like we do. And so there's some weirdness in stroke in that we use older terms and older concepts to describe what's going on, including the word stroke itself, which used to cover a broad set of different similar appearing presentations when people didn't really understand the difference. And so one of those, an even broader definition is this concept of apoplexy. You might see this word out there from time to time, but it's really an archaic medical word that basically means someone who has an acute loss of mental status. So they're talking to you right now and then they lose consciousness. So obviously this covers a ton of different things. This covers seizure, syncope, cardiac arrest, really, intracranial hemorrhage, ischemic or thrombotic stroke, intoxication, all kinds of different stuff. Just having the vapors and having a psychogenic syncope or something like that. All of those things fell into this concept of apoplexy. And really what apoplexy means when you translate it into English is to be struck down. And to be struck down is where the concept of stroke comes from, or at least the term of stroke comes from. And this idea of being struck by lightning and suddenly falling down. So when we say that someone had a stroke, it's this idea of that acute change that fits into that. And specifically an acute change in neurological functioning, mental status. So again, apoplexy has been known forever as a medical problem. It includes cardiac arrest, stroke, epilepsy, massive P, etc., etc., etc. But anything that causes a sudden death or disability. In about the 1500s to 1800s, we started to understand the vascular nature of stroke and the idea that this was coming from blockages within the arteries in the brain. In the 1970s to 1980s, we developed an understanding of how to do risk mitigation for stroke. We didn't have many treatments for stroke. We were pretty good at diagnosing that after the fact, but really what damage was done was done. But we started to understand blood pressure management, cholesterol management, these things that reduced the risk of patients having a stroke, and we started to reduce the frequency of stroke. Then in 1995, we had the introduction of TPA, where we actually started to have an intervention that could possibly help improve outcome in stroke. And now most of our stroke programs in hospitals in the stroke system is based around these interventions that we have, including systemic TPA, intra-arterial TPA, where they put it straight into the brain, or physically going in and pulling out the the blood clots. So I do want to talk, when we talk about different kinds of stroke, is something that always came up to me is, why do we call heat stroke when it's clearly not anything to do with stroke per se, like we talk about? And it's this idea of this acute onset of a mental status change. And heat stroke goes back in time historically to this concept of the noon witch. So people would take lunch breaks at noon to avoid being struck by the noon witch. That would, if you had exertion in the heat of the day, could happen. And so that's where the lunch break comes from, where we have people who are trying to not be outdoors working during the heat of the day to prevent heat stroke. The Boy Scouts, if you go back and teach, and sometimes they still teach this, that the cardinal concept of heat stroke is lack of sweating. But that's actually incorrect, and a lot of people are dead because of that concept, because people who are well heat acclimatized can actually sweat through heat stroke. But if we think about the word stroke meaning to be struck down, that tells us that we're thinking about mental status, and if the patient has altered mental status, we are in play for heat stroke. A little bit different to have heat syncope, where somebody passes out from dehydration, standing up for a prolonged period of time, but immediately comes back to normal consciousness afterwards. That's a different entity. This is when someone is still confused and having mental status changes after heat exposure that's not rapidly reversing. And the reason we care about this is that heat stroke itself has up to a 75% mortality. So that's higher mortality than regular stroke does. And what they die from is usually multi-system organ failure or severe brain injury from the excessive heat. And so we want to be very, very aggressive with stroke. Especially, I'm recording this on a 96-degree day here in Denver. This is something that we're going to see more and more of in the pre-hospital setting. But let's get back to stroke when we start talking about ischemic and hemorrhagic strokes. So a hemorrhagic stroke, we have some CT scans there. This is when the patient's neurological dysfunction, which is the hallmark of stroke, is caused by bleeding. So these are intracranial hemorrhages, interparenchymal hemorrhages, or bleeding within the structure of the brain that is causing neurological dysfunction because it's pushing on those structures and making them not work. And you can see on the MRI here, you can see some of the inflammation around that big blood clot on the left side of the picture, which is the patient's right side. That's the big white thing on the CT scan. Now, an ischemic stroke is different. That's where we have a blockage to an artery that's feeding part of the brain, and all of the brain tissue downstream, because it's an end organ, dies, or at least is stunned, or eventually dies because of lack of circulation. So really two completely opposite mechanisms. One is a blood vessel bleeding, the other one is a blood vessel that's plugged up, both of which cause acute mental status changes, and therefore both are called stroke, just like heat stroke is called stroke. So those two things kind of get lumped together, and actually in our stroke processes in hospitals, those two disease processes are actually measured together, even though they have very, very different treatments. So that gets to the next question of, why do we need a CT scan so quickly in stroke? And the reason why we need a CT scan very quickly in stroke is because we really want to make sure that we're not missing a bleed, because we want to differentiate between this CT scan on the left side, which is normal and isn't showing anything, versus a CT on the right, which is showing us a large left-sided bleed. That white stuff in there is blood. Because if we think back, our intervention is TPA, which dissolves blood clots and opens up arteries. If we have a patient who's already bleeding and we give them a drug that dissolves blood clots and opens up arteries, that bleeding is going to get worse. So if we gave the patient on the right TPA, it would be likely fatal for them because it would accelerate their bleeding. So when I'm getting a CT scan in a stroke alert, I'm not looking for the stroke itself. I'm hoping the CT scan is normal, because within the treatment realm of 4 hours or even up to 24 hours for intraarterial treatment or other neurointerventional treatments, my CT scan should still look normal. That tissue shouldn't show the changes that happen when it dies until at least many hours out, usually a day out. So if I have a stroke alert that goes straight to the CT scanner, if I'm going to treat with TPA, I'm looking for a normal CT scan. If I see bleeding, I pivot out of the TPA pathway and I go into the intracranial hemorrhage pathway, which again is still tracked by the stroke programs, but it's a very different mechanism, different treatment, different goals. So in hemorrhagic stroke, our goal is directed at control of bleeding and controlling that mass effect. If there's enough blood, we actually have to remove a chunk of the skull to be able to decompress the brain. We're going to do blood pressure control to try to decrease the rate of bleeding. If they're anticoagulated, we're going to reverse those. If there's a ruptured aneurysm, they're going to either have the neurosurgeon open up and go in and clamp that, or the neurointerventionalist go up and put a little coil on the inside of that clots off the aneurysm and stops it from bleeding. And if there's extra swelling, either from the irritation of the blood or swelling from just there being more blood in the skull than the skull can handle, they'll take that chunk of skull off to allow the brain to basically expand temporarily, eventually closing that back up. And very frequently we medically manage these intracranial hemorrhages. If they're small and they don't need surgical decompression, they usually stop on their own with anticoagulant reversal. We watch them and we manage issues like seizure from the irritation of the blood. Ischemic stroke, the management is directed at opening up the blocked vessels. We'll give them aspirin. We'll allow their blood pressure to remain slightly high so that we're continuing to have a good cerebral perfusion pressure. If they're within the window, we would do TPA intravenously, or potentially later on we'll have a longer time frame where we could do our intraarterial TPA, or physically go in and remove that thrombus and do a thrombectomy. So when I'm looking at a patient who's in a stroke presentation, there's some symptoms that kind of make me point one way or the other of hemorrhagic versus ischemic. Obviously, it's not going to point me enough that I'm going to go ahead and give TPA without a CT scan, but we can get some general ideas of what we're thinking about. If I have a patient who presents with a severe headache, I think hemorrhagic stroke. Ischemic strokes are usually painless. Seizure, again, that blood inside the brain and outside of the blood vessels is very irritating to the brain and inflammatory, and it can cause seizures. Obviously, a patient who has trauma and now stroke-like symptoms, I'm going to think of a bleed. Anticoagulated patients, I'm going to favor bleed, although many patients are anticoagulated because they've had a stroke and they're high risk for stroke. So that one's a little bit of a push. Symptoms that are slowly progressing over time makes me think hemorrhagic, makes me think of something expanding, pushing on more and more stuff. If I have someone who has profound altered mental status, that favors bleed in my mind, although some people with a massive stroke or a large hemispheric stroke can really have some significant mental status issues. And then certainly the younger the patient, the more I think hemorrhage, because they usually have healthy blood vessels, although some people can have an inflammatory or autoimmune vasculitis or throw blood clots from paradoxical emboli because they have a little hole in their heart. Now, if I see patients who have slowly improving symptoms, that makes me think ischemic stroke. That makes me think of an artery that got blocked and is now opening up a little bit, usually painless. History of atrial fibrillation, because those patients get clots in their hearts and then throw them north up into the neurocirculation, that makes me think of that. Unilateral symptoms, certainly, I think of ischemic stroke, although a unilateral hemorrhagic stroke can do the same. Primarily speech and motor systems, because that middle cerebral artery seems to get hit very frequently, they'll present with isolated speech and motor problems. I think more ischemic stroke. And then the posterior strokes, the dizzy, clumsy, vertigo, vision changes. That makes me think posterior. So why do we get progressive symptoms in hemorrhage? It's because if that bleed keeps going, it pushes on more and more structures. Here's a CT scan that shows intracranial hemorrhage. On the left is an early CT scan, and on the right is a follow-up, and you can see that bleed is getting bigger and bigger over time. So in a hemorrhagic stroke, you start to see more and more progressive symptoms. And then why, fixed or improving symptoms of ischemia? Because there is some redundancy in the circulation in the brain. We have the circle of Willis. Circle of Willis sits at the bottom of the brain, so this is a picture of the brain from the bottom with the carotid arteries coming up there, and they basically branch off to form the middle cerebral artery, the anterior cerebral artery, and then connect to the basilar artery through this circle of Willis. So the cool thing here is if I block one carotid artery or the other, I can get flow from the opposite side. So if I throw a blood clot and it gets stuck in a big artery, I may get some redundant flow, and then also that clot may get broken down by the body itself. The body makes TPA, and slowly get smaller and move upstream to where it's blocking smaller and smaller arteries, and other parts of the brain are getting perfused again. And then the thing we want to think about are what parts of the brain get affected by these different strokes. And so the anterior cerebral artery, so this picture of the brain, the front of the patient's face is on the left, and their back is towards the right. Up and down is correct for A and B. And the first picture is looking at the brain from the outside, whereas the second picture is if we slice the brain down the middle, we're looking at the medial part of the cortex. So that bluish color, that is where the anterior cerebral artery covers. It gets some of the frontal lobes, it gets some of the stuff that sits there in the middle. The functions that are regulated by that are fairly subtle to see because it's not affecting speech, vision, or motor function. Whereas the middle cerebral artery, that yellow territory, that's going to cover on the left side the patient's speech areas and also their motor strip, which controls most of their motor function in the body. So you'll see the patients who have that typical presentation where they have speech problems. If they have a left-sided stroke, the left side of the brain feeds the right side of the body, so they'll have speech problems because their speech circuits are located on the left side for most right-handed people. And then they'll lose function of their right hand and maybe their right leg because they're losing that motor strip, and they'll have the paralysis there. The red side, pink side, is going to cover the posterior cerebral artery. That's going to cover visual cortex. So you'll have people who lose vision of half of the universe because they'll lose the vision, the processing and vision of both of their eyes on one side but not the other. They'll also potentially lose some balance issues, which is not shown here because the cerebellum is also perfused by the posterior cerebral artery. And so, if we look at this middle cerebral artery, or MCA, and again, I'm kind of dating myself with my musical tastes here, that MCA effect is what really causes those typical strokes. Now, the problem with the typical strokes is that people still can get anterior circulation and posterior circulation strokes, but because they're subtle, they frequently get missed. Because they frequently get missed, we live in this self-fulfilling prophecy that middle cerebral artery strokes with the weakness and typical speech changes are the most common strokes. It's more that they're the most common strokes that we diagnose and that we find because we frequently miss the other ones, that we were undercounting those. So thinking about that circulation pathway, that middle cerebral artery is typical, but the posterior cerebral artery circulation can also cause debilitating strokes, but has more subtle symptoms. Vertigo, clumsiness, difficulty walking, nausea, vision changes, things like that, which really can be caused by many, many things. So then if we think about our plumbing issue, and we think about hemorrhagic versus ischemic plumbing, for our hemorrhagic plumbing, or our ischemic plumbing, we're going to think of like our sprinkler lines when we get something that's choking them off. Although usually in the brain, what's choking it off is internal, it's plaque. It's arteriosclerosis and plaque, just like we get plaque in coronary arteries, that is slowly filling that up. And then if that plaque breaks open, the lipid is very inflammatory and irritating, and it forms a blood clot there. You also can get blood clots that travel from other parts of the body, specifically the heart, or potentially from DVTs. If the patient has a hole in their heart where it can cross from the right side to the left, you can get that embolic stroke where blood clots are traveling and then landing in the cerebral circulation. Versus hemorrhagic plumbing, which is like the floor is lava here. Their blood is leaking out, and it's leaking out and getting everywhere. We also want to think about things like stroke mimics. So what stuff can look like a stroke? So things like trauma or traumatic brain injury, complex migraine, overdose, hypoglycemia, DKA, sepsis. meningitis, encephalitis. Todd's paralysis, where you can have a partial paralysis and speech problems after a seizure because the area of the brain that was seizing is now stunned and not working temporarily. So people can wake up after a seizure and look like they're having stroke symptoms. Brain tumor, brain abscess. Now malingering, I'm going to put in there. We always want to be very cautious of diagnosing malingering because we're just not that good at diagnosing things. Specifically in the ED, we can still miss a lot of stuff. Definitely in the pre-hospital setting, we have no real diagnostic tests for these. So we want to be very, very careful when we're saying somebody's faking acute mental status changes. Even though, yes, I agree, they do. We want to be cautious because when you tell someone who's having an acute medical problem that you think they're faking, that really undermines not just your credibility, it actually undermines their trust in the entire medical system. So be very cautious with that. Patients who have old strokes and then decompensate for other reasons, maybe they get septic or a urinary tract infection. Multiple sclerosis can look like a stroke, a little bit slower onset. And then Bell's palsy is a very common stroke mimic where you get paralysis of the facial nerve and isolated facial paralysis, which can look a lot like a stroke. Now the cool thing about all these things that look like a stroke is my workup is the same. I'm going to look for the dangerous thing, head bleed or ischemic stroke, and I'm going to rule that out and then look for all these other things too. So that's the cool thing about the stroke alert is it's designed to be a bit of a catch-all where it's going to be very good at diagnosing stroke and it's going to be very good at diagnosing stroke mimics and treating them and supporting them. So even if patients are having a stroke mimic, they benefit from the stroke alert process because they're getting that acute rapid care and getting this other stuff evaluated and ruled, either diagnosed or ruled out. So timing of treatment. TPA needs to be given as soon as possible, but no later than 4 hours after a symptom onset. So the longer you wait, the more tissue dies and the more risk of bleeding from TPA. So over time, you have a greater and greater risk of bleeding, and more of that tissue is irreversibly dead. So there's less decreasing benefit over time, increasing risk. And at 4 hours for IV TPA is where we have a crossover for the risk to the benefit, where the TPA becomes more dangerous than it becomes helpful. The intraarterial TPA, they can go out further. Thrombectomy, they can go out further. So in the hospital, we'll call a stroke alert within 24 hours of onset, or 24 hours of last known normal if we can't figure out exact time of onset. Last known normal is really key because we don't want when the patient noticed that they had the stroke, we want to know when was the last time we knew they didn't have a stroke. And so we can give the intraarterial TPA up to 6 hours, maybe a little bit longer, thrombectomy 24, and so stroke alert can be called up to 24 hours of onset. We have a specific protocol at North Metro where we're using a shorter time of, we're using a bit of a shorter time in collaboration with the local hospitals up there. Certainly presenting this as what's going on, letting the hospital choose how they want to do the stroke alert and whether or not we're going emergent, that's going to be a specific discussion with each agency and each landscape and catchment area and destination stuff to take into account the risks of going emergent when we're very far out from an acute stroke. So we can talk about those things specifically agency by agency. So what is our pre-hospital stroke care? So again, the cool thing here is all pre-hospital stroke care falls within BLS scope. Because this is things anybody can do, any provider can do, which is cool. So our A, B's, and C's are important because good supportive care is key. Ischemic brain hates low blood pressure or hypoxia or hyperventilation. So we want to be very cautious with those things. We want to know the time of onset or last known normal. We want to get an accurate med list. We also want to know DNR, who is the power of attorney, who's the family contact, because we need to consent people for some of these treatments, and being able to figure out who those people are and get in touch with them quickly is very important. So if they just happen to be saying, I'm going to get to the hospital, and they show up an hour and a half later, that makes it really hard for us to use them as a to help understand what the patient would want if the patient's unable to talk to us or unable to understand what's going on. Also, the thing you guys can figure out, is there any chance this could be trauma? And so did the patient have a stroke and then fall? Did they have a fall and then bleed? Or did they have a stroke and then fall and then have a traumatic brain injury on top of their stroke? So getting that story and that picture as best you can from what you're seeing helps me out, because once the patient's on a gurney rolling into the ED, I don't have any of that context, and that can change. What am I going to look for? Am I going to add in CT cervical spine? Do I need to look for an intrathoracic or intra-abdominal injury before I give this patient something that's going to make them bleed from anywhere that bleed hard from anywhere that they're bleeding slow right now? So that helps out a ton. And what's our stroke exam? Really the very basic stroke exam is going to be looking at facial droop. It's going to be looking for if they have speech issues, and then looking for pronator drift. And so I'm going to show you pronator drift here. So if I just have someone do kind of a Frankenstein arms here, and then have them hold there like this with their eyes open, they're going to look. And if they're getting a little weak, they're going to start correcting this. So I can become more sensitive if I make the patient close their eyes, because now they can't tell if that arm is starting to drift down. I can get even more sensitive if I have them rotate their hands upwards using that pronator muscle, because it takes some work to hold your hands palm upward. And now if I close their eyes, I can see very subtle weakness in the pronator muscle, where one of those hands is going to start to lose pronation. That's the subtle thing. If they have global weakness, it's going to fall. And sometimes you can catch people who are playing little games with us where they want to fake being weak. They don't know they're supposed to pronate, and so they'll look weak by just lowering that arm with strong pronation. Now again, are there strokes that can just get this section of the arm? Sure. So we're not going to hang our hats on that and call someone a liar because of one finding. But if I'm looking for someone where I'm not really sure what's going on, there are several neuroexam findings that are difficult for people to understand unless they're been trained by a neurologist. Difficult to understand what the finding should be. And so if they're trying to fake it, they fake backwards. And so anyway, and we can talk about that later on. It doesn't really apply to our care in the pre-hospital setting. So we have our Cincinnati Pre-Hospital Stroke Scale is what we would use. There are additional stroke scales that we can add in that add a little bit of sensitivity. There are also stroke scales that will add in more sensitivity to posterior strokes, which you'll see in the other gray box on the right here. And so the Cincinnati Pre-Hospital Stroke Scale is very specific for stroke in that if you have a positive Cincinnati Positive Stroke Scale, you're probably having a stroke. If you have a negative Cincinnati Pre-Hospital Stroke Scale, there are other strokes that can basically not show up with facial droop, pronator drift, or speech issues, mainly posterior strokes. And so those things where we have impaired balance or coordination, vision loss, headache, confusion, or altered mental status or seizure, that could be suggestive of a stroke, but certainly we get less less specificity if we include those symptoms, because we're starting to catch more and more of those stroke mimics. So that gets us through our stroke learning goals. And our next section, we're going to talk about traumatic brain injury. If you're watching these one by one, go ahead and check out the traumatic brain injury one next. If you're looking at this where it's all stuck together, we're just going to go straight into that one. And if you're going to take a quick break, this is a good time to do it. All right, guys, moving on to the next section of the Brain Day series. If you haven't watched the first section on stroke, you can go back and watch that. If you've already seen that before and you just want to watch this part on traumatic brain injury, that's totally cool as well. Or if you're watching all three of these in a row, they're all kind of stuck together, so you guys already know what's going on. So this is a presentation that's originally was made for Pleasant View Fire Department for their third quarter EMSCE training. We are recording this because the first shift we went to go present to had a structure fire, but we figured we'd record this and make it available for North Metro and Lafayette as well, for anybody who wants to get that, and then generally available for folks who just want to watch online for information. If you are not in one of those three agencies, then this is strictly educational. So this is if you're not under my medical direction, this doesn't constitute medical direction. It is educational and informational, and your care needs to conform to your training, local protocols, guidelines, medical direction, and your agency SOPs or SOGs. So with no further ado, let's move on. We already covered the stroke topics, so now we're going to do a discussion of traumatic brain injury. And this section is based off of the traumatic brain injury training that we did earlier in the year for Thornton and North Metro, so it's going to be very similar to that. And we're going to look at how traumatic brain injury fits into general trauma management. We're going to talk about prioritization of care, going beyond the X, A, B, C, D, E issues, so that when we have 10 things that we need to do and only time to do 3, which 3 do we pick, and then which order do we do those 3? Because that matters. It matters to getting the mission done of getting what we need done for the patient's highest yield and giving that patient the best chance of getting home back to their families again. We're going to cover the EPIC TBI study, which was a study that is actually still ongoing down in Arizona, but that was starting back when I was training down there as EMS fellow. And then we're going to talk about application of these 3 basic concepts of avoiding hypoxia, avoiding hypotension, and avoiding hyperventilation in patients with traumatic brain injury, and the reasons behind that. So if we think about a patient, if we are called to a motorcycle accident, we find the motorcycle looking like this. We see the patient unhelmeted with a large obvious external head injury, but also altered. We see a bleeding arterial injury to the left lower extremity, and then we see obvious abrasions and blunt trauma to the abdomen. This is a full plate, especially if you're a medic in an EMT in one medic unit or 2 paramedics in a medic unit. When you don't have a lot of hands, we're really going to need to figure out what we need to do first. So let's think about why I make the case that traumatic brain injury should be the part of this that comes first, although we may manage the other injuries first with the intent of perfusing that brain, preserving that brain perfusion. So what is the EPIC TBI study? It was an NIH-funded, NIH-funded statewide pre-hospital research study down in Arizona. 22,000 patients collected over several years, adult and pediatric arms of the study. And the design was a manual review of old PCRs connected to hospital charts in the trauma registry. And they did that manually so they actually go and look and see, did they have end-tidal CO2s? What were the end-tidal CO2s? If they were able to actually get hold of the downloads of monitor data where they have the real-time measurement of oxygenation, blood pressure, CO2, heart rate, and things like that. Respiratory rate too, which is important. We'll talk about that. Then they would do a training intervention, a guideline implementation phase, and then after that they would review PCRs manually going forward, again connected to hospital charts so they could look at what injuries the patient had and what kind of outcomes they had. And then basically look at how did agencies do before and after, how did the whole state do before and after this intervention. Bottom line up front, they had massive survival benefit to severe traumatic brain injured patients from this simple educational intervention. So what was the evidence-based guidelines? It was to aggressively prevent and treat 3 H-bombs of TBI. The H-bombs being hypoxemia, hypotension, and hyperventilation. All of those things will cause worsening of traumatic brain injury and worse outcomes. So traumatic brain injury, we can separate into primary and secondary brain injury. Primary brain injury is the injury that happens immediately. It's the direct trauma. Those neurons are dead. They're not going to be alive again. No treatment will make them better. That is fixed. Secondary brain injury, we have injured neurons that are on the cusp where they can either heal or they can die off. And the treatment focus here is prevention. And what causes them to die off is not enough oxygen, not enough blood pressure and perfusion, and then also if we hyperventilate the patient and cause vasospasm and decrease cerebral perfusion from the hyperventilation and the high pH from low CO2, that's going to cause killing off of more neurons because that's going to decrease perfusion. And secondary brain injury is a major contributor to outcome, but it's also the part where we actually have some play and we can do some good. And the premise of the EPIC traumatic brain injury study was the pre-hospital providers who are the first ones taking care of these patients with severe traumatic brain injury or that may develop severe traumatic brain injury or decompensate in the pre-hospital setting, that they have the most, they have a very large role, a disproportionately large role, because preventing hypoxia, hypotension, hyperventilation in the pre-hospital setting gives the neurosurgeon and the trauma surgeons a healthy brain to work with. The opposite of that is if we cause hypoxia or allow hypoxia, allow low blood pressure without managing it, or hyperventilate the patient when we get control of their airway, we're going to start killing off neurons that don't need to die, and we're actively going to be causing harm. So what's the plan? We stop these 3H bombs. So we're going to prevent and treat hypoxia. Threshold is we want to keep that patient above 90% all the time. And what they taught was to approach all potential traumatic brain injuries based on a altered level of consciousness and then requiring transport to the hospital, which is a pretty broad catch. They wanted immediate, continuous high-flow oxygen via non-rebreather on all of those patients. That's a big practice change for us. We've been taught a little bit that we don't want to over-oxygenate our patients. In traumatic brain injured patients or potentially traumatic brain injured patients, the risk is very, very low compared to, the risk of damaging the patient by over-oxygenation is very, very low compared to the risk of harming them by allowing hypoxia to happen. And so we want to have them hyperoxygenated or pre-oxygenated, because if that patient loses their airway, loses their mental status, or becomes hypoxic because of their other traumatic injuries, that's going to cause worse outcome to the brain. So what we're doing is we're trying to prevent that. So in this setting, you can't hyperoxygenate the patients. So they should all get good aggressive oxygenation. If there's any sign of inadequate oxygenation, then we're going to start assisting the breathing by BVM, but we're going to intubate or do a supraglottic airway only if inadequate oxygenation with BVM. And the caveats are if the patient is vomiting or high risk for aspiration, because obviously that's going to cause airway and oxygenation issues, or for agencies that have a very long distance transport from the hospital. None of the agencies under my direction that this is intended for have that, but if you're watching this and you do have a long transport time, airway management may have greater benefit if you're going to have a long transport time. So again, think about that in your own setting. Talk to your own medical director about the best plan for that. We want to prevent, if we're going to intubate the patient, we want to prevent hypoxia during intubation. So this is where that pre-oxygenation comes into play. Because we don't want to let this happen during intubation. This is a traumatic brain injured patient from the study where they pulled the saturation over time. And you can see this patient was oxygenated 100% before intubation. So it wasn't like, the patient had massive pulmonary contusions or something that was preventing oxygenation. And the patient dropped all the way down into the 60s for a full minute. And really 2 minutes of significant hypoxia during intubation, and then right back up to 100%, again, arguing against there being any big structural problem with the lungs causing this hypoxia. This was just strictly a prolonged intubation where the patient was allowed to become hypoxic and they weren't really paying attention or didn't pre-oxygenate adequately. So we want to avoid that, because even though we might get a solid airway and now we're oxygenating the patient great, if we just lost so many neurons during that hypoxic issue that the patient never really wakes up again to see their family, that's not really a big win for this patient to survive but never to wake up again. We also want to avoid hypotension. So in the study, the goal was systolic greater than 90. And so they also said lean into this a little bit. Don't wait for the patient to get below 90 to start your crystalloid. If the patient's trending down or the patient's approaching 90, you want to get aggressive and prevent the patient from going below 90 rather than treat below 90, which is a little bit of a different approach from a patient who doesn't have a traumatic brain injury but has intra-abdominal or intrathoracic trauma. We're going to be very cautious of giving crystalloids in those patients and hold off a little bit, because a little bit of transient hypotension isn't going to be as dangerous in a patient without a head injury as it is in a patient who does have a head injury. And their protocol was initial 1 liter bolus, again, greater than the Denver Metro protocols, repeat 500 cc boluses, and our intention is to never allow the patient to get below 90. We're not going to resuscitate them up to 120 over 80, that's not necessary, but we don't want them to get hypotensive. And then also aggressively prevent and treat hyperventilation. Now, if a patient's breathing on their own and they're hyperventilating for some other reason, there's not much we can do about that other than control their pain, control anxiety, and basically work on the psychogenic effects of that. The patient may be having an acidotic problem where they're breathing fast in order to normalize their pH. So in the awake alert patient, there's not much we can do. But if we have control of the airway and we're bagging them, we need to make sure that we're doing this at 10 breaths per minute with just enough air to let the chest rise, which is going to be about 500 cc's, which is about a third or a quarter of how much capacity is in a bag on a bag valve mask or a bag valve system for patients intubated. And so giving that whole breath and giving it more than 10 breaths per minute is going to massively hyperventilate the patient, causing vasospasm in the brain, causing decreased perfusion to injured brain. The two-finger bag technique, one-finger bag technique, basically you're just using, you don't want to grab onto that bag and have the biggest dudes you have just empty out that bag with every breath. They make flow-controlled bags where if we're breathing too fast for them or being too aggressive, it pops off because of the flow. And then having a ventilation rate timer. If you're having the person bagging, watch that monitor and look at the respiratory rate that's on the end tidal CO2 and keeping it at 10, that's key. You also should probably have a spotter spotting that patient. We'll talk about in the next slide, spotting the provider who's bagging the patient to make sure that they're doing 10 per minute because it's painfully slow. Here, I mean, just here on this video, let's take a look here. I'm gonna pretend I'm bagging a patient. So start a watch here, breathe. 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 So that's annoyingly slow when you're watching a YouTube video here. It's a ton of dead air. And that's 6 seconds between breaths. That's the appropriate rate. In a high stress environment, that is impossible to maintain without either having a metronome, a flashing LED light that flashes every 6 seconds, an app on your phone that does that, watching the monitor and doing that, or actually looking at a watch and doing it, or having a spotter do it. Otherwise, it's impossible because your brain can't process time accurately enough to do it in a high-stress situation. We need to have end tidal CO2 monitoring from the very first breath that we're giving the patient if we take over their airway. Our target is 40 millimeters of mercury. We're going to have that range be from 35 to 45, and that the EMT who's bagging the patient is the most important on the team if we're controlling that airway. So important, they should also have a spotter to make sure that we're staying within the range and we're not hyperventilating. We're never going to hyperventilate for, I think the patient's herniating. And there's some reasons behind that we can go into in more detail. But basically, the design of this study, and I think good science shows that pre-hospital herniation is extremely rare. So generally what happens is patients aren't actually herniating, they just have a severe traumatic brain injury without herniation if they're going to get hyperventilated. And then the other issue is that if the patient in the pre-hospital setting is already herniating, the likelihood that we're going to save that patient is essentially zero, because that patient needs to get to the hospital, get to the OR, get the neurosurgeon into the hospital, get the brain decompressed, and maybe do a couple of other temporizing things like hypertonic saline or mannitol. But to just hyperventilate the patient, to decrease circulation, to hope that that's going to help them, the problem is that all the patients who don't need it, that inadvertently get hyperventilated because we think they might be herniating, they're being directly harmed. So we don't ever want to hyperventilate a patient in the pre-hospital setting for possible herniation. We're just going to do normal ventilatory rate, aggressive oxygenation, aggressive blood pressure, rapid transport, and do all the other supportive care well. Now here's the issue that we come up with we call this inadvertent ventilatory inattentiveness. So this is when you don't notice that you're hyperventilating the patient. So this is a patient who gets intubated. You can see the end tidal CO2 is measured there, and they're kind of at the low end of the range to start off with, and they're bagging at looks like about 20 a minute, but very quickly that patient gets up to where they're getting bagged at almost 40 a minute. And you'll see sometimes where it drops down, where they notice that they're hyperventilating the patient because they look at the respiratory rate and they slow down, but as soon as they look away, that rate goes back up again in that second graph. Obviously the patient is saturating just fine. He's at 100% almost throughout this. Blood pressure is just fine, but you'll look at this end tidal CO2 over time. And after 10 minutes of that, the patient's going down, or sorry, not even 10 minutes. After 5 minutes of that, the patient is well below the threshold of 35 millimeters of mercury trending down. Eventually they get down all the way to 20. This is devastating for the cerebral circulation. So in the study, who was an epic patient? So if we're going to extend this into our setting, who are we going to think of? It's basically a trauma, even a ground level fall, that has sufficient injury to be transported to the hospital and any loss of consciousness. I don't remember, I saw stars, I was out for a few seconds. If there's perseveration, which is repetitive questioning, where they keep asking you the same thing over and over again, or altered mental status. But also keeping in mind that a GCS of 15 does not exclude a major traumatic brain injury. So just because they do have a GCS of 15 doesn't mean that they're not in play for bad stuff. This is a repeat of that previous slide, but again, if there are any kind of trauma that's sufficient to be transported to the hospital and any loss of consciousness with it, they're in play, because even if they're awake and alert, they can decompensate in front of us. If they're bleeding and that bleed's getting bigger and bigger, if they're just compensating for it, if they have a seizure because of their traumatic brain injury, any of these things are going to be bad for them. Which includes, if we had a seizure with the trauma, that's going to be an inclusion criteria, or was for the study. Or so that's a seizure leading to TBI, or a seizure after the TBI, which tells us a post-traumatic seizure. That argues for possibly dangerous brain injury. Multi-system trauma requiring positive pressure ventilation, either basic airway or an advanced airway. That was falling in because those patients have a high frequency of traumatic brain injury with it. And then risk factors, not necessarily ruling in, but older age, even over the age of 40, which kind of breaks my heart. And then if they're on any anticoagulants, they're at higher risk for severe traumatic brain injury. What if I don't know if they had loss of consciousness? Head injured patients are poor historians, so look at the scene, do your exam, what's the mechanism? Reports from police or bystanders. The patient's perseverating after the fact. What are the risk factors? So get that whole picture to say, this patient could have had a decent traumatic brain injury. I need to be very cautious about all those things. Avoiding hypoxia, getting oxygen on them, monitoring the blood pressure and being ready to correct it if it starts to drop, and then remembering that if I have to control their airway, help them breathe in any way, I don't want to hyperventilate them. So if we look at the data, what did they find when they spit this out at the end? So this is one of the studies that came out of this. This is out of JAMA, so basically the highest impact journal we got in medicine, really. And what they found is they found a lower rate of intubation in these patients after training. So they were managing more of these patients with bag valve mask or BLS airways, even though the patients had greater injury severity. There was a much higher rate of BVM-only airway management. So basically, we were doing a good job of communicating the goals that the advanced airway is not necessary in these patients and may actually be harmful because it allows you to hyperventilate them. There was a greater likelihood of the patient having a saturation of 100% at some point in the pre-hospital setting. There was greater reversal of hypoxia by the time they arrived at a trauma center. There was a greater likelihood of receiving a fluid bolus in hypotensive and near hypotensive patients after the training than before. A greater volume of fluid was given in the hypotensive and near hypotensive patients, and a very much lower rate of hyperventilation and hypocapnia in these intubated patients. So people were watching it and they were actually doing what we asked them to do. So that was pretty cool. That you can do this very simple training intervention on folks, and that actually has an outcome that you can see in the chart. The patients are getting the interventions you're telling the providers that they need. So that's pretty cool. Now this is the really cool stuff. So survival to hospital discharge and severe traumatic brain injury. What they found is they found an adjusted odd ratio of over 2 for severe traumatic brain injury. So that means doubled the odds of survival to hospital discharge with this training intervention, which is all BLS stuff, which is super cool. By doing good supportive care, doing good BLS care, we can double the likelihood of the patient surviving. If we look at something like TPA, which we TXA, which we use a ton of in trauma, and we've done a lot of training on that, have a lot of waivers in place for that. The benefit's very, very small. It's nowhere near a doubling of odds ratio, and it requires a fancy drug and a very specific patient population, and it doesn't do very much, and we do a lot of effort on that. We can do less effort, easier interventions, and have a greater outcome with this particular strategy of managing traumatic brain injury. Now, if you just looked at the intubated severe traumatic brain injury patients, they had a tripling of their adjusted odds of survival to discharge. And their average was about 30 minutes of EMS care, because it was a statewide study. There were a lot of agencies that had long transport times. That 29 minutes of EMS care affected survival to hospital discharge. Now, in pediatric patients, it was even bigger. For severe traumatic brain injury pediatric patients, they had a five times increase in their adjusted odds of survival, as either severe TBI or intubated severe TBI. And the positive pressure ventilated patients, so patients who got bag valve mask, so that includes intubated or BLS airway, they had a 7-fold increase in adjusted odds of survival from comparing patients before they had the training intervention in the agencies to after the agencies had the training intervention. So that's a 7-time survival rate in kids who have the most to lose, the most years to lose of having the debilitation of a severe traumatic brain injury and the sequelae of that, or maybe they don't survive. Well, these are odds of survival, actually. So these are odds of actually going home. So we have kids now who have a 7-fold improvement in how likely they are to go home by doing these 3 simple things. So what's the take home? This is a massive benefit. So there's about a 10 to 15% improvement in survival for TXA. This is between a 200% and 700% improvement in survival for the EPIC TBI study. Low cost. This is all basically just training stuff like what we're doing now to just introduce the concept versus having dedicated protocols and dedicated training on this. It uses skills and equipment we already have. We don't have to buy more drugs or put in different waivers or have any other cool stuff or cool gear. It focuses on high quality BLS care, which we all know high quality BLS care is really has a huge bang for the buck. It requires good CQI and feedback. We got to review these charts and we got to get feedback to providers. Be like, hey man, this patient had a bad traumatic brain injury. You intubated them and their end-tidal CO2 was in the 20s afterwards. That's a problem. Let's work on that. And then also incorporating this into a bigger picture trauma plan of pre-hospital blood alerts that we're working on with multiple agencies, airway ventilation focus, and scenario-based hands-on training. So we're not just talking about this in a PowerPoint like today, but actually practicing this stuff and getting the feel for it. So let's go back to this patient. We got a patient with an obvious severe head injury. He's unresponsive. He's got external injuries, no helmet, and a nasty mechanism. He's got an arterial bleed to the left lower extremity, and he's got obvious trauma to the abdomen. So if we think about our priorities here, obviously the very first thing we want to manage is that severe arterial bleed to the leg. And I'm going to argue that that's actually a treatment of his traumatic brain injury, because if I let him bleed and he becomes hypotensive or becomes anemic and can't transport oxygen to those injured neurons, they're going to die off. So my first traumatic brain injury intervention is going to be to throw a tourniquet on that patient and get that massive hemorrhage controlled so that I can keep more blood in the patient. I can avoid hypotension in the patient. There's not much I can do directly about that intra-abdominal injury, but I'm going to be ready for that dude's liver to be trashed. This guy is in play to become hypotensive. Maybe it's just road rash and abrasions, but there could be bad stuff happening in there. I'm going to get 2 large bore IVs. I'm going to be set up to give fluids. For that wound on the head, if there's no arterial bleed there, I'm not going to do much for it other than cover it. Obviously, I'm going to worry about a cervical spine injury, because if he survives but then is paralyzed, that's not really a big win for him either. And then I want to think about, if this guy's altered, what am I doing to oxygenate and ventilate the patient through the least invasive means necessary? First off, before I even get an oxygen saturation on him or monitoring, I want high flow on this guy. I want him pre-oxygenated, because if he can't maintain his airway, I want to get as much oxygen in his air as I can. I want to get my, somebody on the team, anyone who can, an EMT, to get the bag valve mask ready to go and support the patient's ventilation if he's becoming hypoxic with high flow oxygen. Also monitoring the end-tidal CO2. It's hard to overventilate somebody with a bag valve mask, but it's possible, so we need to be careful. And then if I'm going to put a supraglottic airway or intubation in there, I need to have end-tidal CO2 from that very first breath. I need to be giving no more than a breath every 6 seconds or 10 times a minute. And I need to be monitoring and keeping that patient between 35 and 45 end-tidal CO2. And then I'm going to take that patient to a trauma center where they can aggressively manage all the stuff I can't fix in the pre-hospital setting. But if I do those things, I know that, going back a few slides here, I'm going to double the guy's odds of survival from his severe traumatic brain injury that he's having right now if I do those things compared to if I don't, or if I just haphazardly do those things. So I think that's pretty cool. So hopefully you guys can incorporate that in your practice and how you're considering patients with multi-system trauma or patients with head injuries. We'll talk about developing specific protocols and specific training on this going forward. That's one of my projects over the next year or so. So we'll revisit it. Let me know if you have any feedback or comments. And that covers our traumatic brain injury section of the series, second video, or again, if you're watching these all together, they're all just going to string together. Next one, we're going to do a short video on seizure, so tune in for that one. And this is a good time to take a break if you need to. All right, guys, so we're moving into video 3 of our traumatic brain injury, stroke, and seizure brain day talks. Doing this in a couple different formats. If you're watching all 3 of these going all the way through, I apologize for a little bit of repetition here. If you're watching these bit by bit or one at a time as a one-off, that's fine too. But this next video is going to cover seizure, and it's going to be fairly short. Mostly BLS, like the other 2 sections have been entirely BLS discussions. But there will be a little bit of ALS when we talk about anti-epileptic medications. But I want to make sure that we're thinking about seizure at all levels of providers, because really BLS care, good BLS supportive care for seizure is all that most of our seizure patients really end up needing, which is pretty cool. Another quick caveat, sorry if this is the 3rd time you heard this in the video, but this is intended for North Metro, Lafayette, and Pleasant View agencies that I supervise. If you're watching this and you're not in one of those agencies and not under my medical direction, then this is just educational, informational. Thanks for watching, and I appreciate it. But you have to follow your training, local protocols, guidelines, medical direction, agency, SOP, SOGs. So happy that you're watching it, but make sure you're doing what your medical director tells you need to do. So again, our learning goals, we covered stroke and traumatic brain injury in the 2 other videos, or earlier in the longer video if you're watching it. We're going to talk about seizure here. I want to cover a little bit on the mechanism of seizure, and then I want to cover a BLS approach to seizure with a little bit of, we'll talk about midazolam at the end there. So what are we going to talk about here? It's really about GABA. And GABA is a neurotransmitter. It's one of the most common neurotransmitters in the brain. What's interesting about it is it's an inhibitory neurotransmitter. And what do I mean by that? I mean that if we have 2 neurons that are talking to each other, usually when we learn about this in a basic way, we always think of the one neuron stimulating the next neuron and increasing the likelihood that next neuron is going to fire. GABA is weird because it basically jumps in and attaches to neurons, and when the neuron fires and releases GABA, it reduces the likelihood that next neuron is going to fire. So it really acts to slow down neurotransmission generally in the brain and in circuits in the brain, and it also tends to be like brakes in the brain, because if every neuron in the brain was activating the next neurons it touched, then we'd have a feed-forward loop, and we would basically have one neuron that's connecting to another and turning it on, that's connecting to another and turning it on, and we know that all of these systems talk back to each other, so eventually we're going to have feedback, and this is going to be like the microphone at a concert that's basically feedback and screaming, and that's what happens in the brain, which, by the way, is a lot like what's happening when you have a seizure, where you get this overactivation. So what GABA neurons do is, rather than having these red neurons that are basically stimulating the next ones, is they would be in a situation where if they're activated, they're going to affect another neuron and slow it down. So if we throw a couple of GABA neurons in here to see that stimulation, but then slow it down, it's going to act as brakes on the system, and it's going to keep that system from going into a feed-forward loop where it, or a feedback loop where it basically gets overstimulated and burns out. And so, why is it that people are going to seize? And so there's 2 things that can make somebody have a seizure. And one of those, it's either overactivation of the neurons or loss of that GABA suppression that's basically slowing everything down. So first off, seizure is the endpoint of a sick brain in a sick person. So a patient having STEMI can go into VFib, same concept, that the myocardium gets very irritated and excitable when it gets ischemic, and they tend to go into ventricular fibrillation, which is again these multiple feedback loops that are running in the heart, basically making it have disorganized activity. Stimulants can certainly cause seizure in massive overdose. Kind of uncommon. It's pretty rare to see someone without a seizure problem have a real actual seizure on meth or cocaine, but certainly it's possible. Certainly patients who are maybe smuggling it inside their body and they have a balloon of it break open. Seizure is very common in that with the massive overdoses, but the recreational doses, it's kind of rare unless they already have a seizure problem. The other big thing, and this is the most common thing, is withdrawal from other GABA activating stuff. So if I have a patient who's constantly drinking alcohol, abusing benzodiazepines, or just being prescribed benzodiazepines or barbiturates, if those go away, because all of those activate that GABA receptor and are suppressing activity within the brain, those are all depressants, then when you take that away, you can have seizure because now you've taken away this thing the brain's gotten used to having, the slowing things down. And then also the other thing that causes overactivation is things like irritating structural stuff, infection in the brain abscesses, encephalitis, scarring in the brain from old strokes or old injuries, active bleeding in the brain, the blood is very inflammatory, or brain tumors are very inflammatory. All those things can cause seizures. So what are we going to do here? You know, we're the pre-hospital heroes here. We're coming in. And really, unfortunately, not much is what we're going to do for seizures. Because vast majority of seizures are self-resolving, which is cool. And if they're not self-resolving, we call them status epilepticus. So the things that we're going to actively intervene on with medications are going to be status epilepticus, which is a small fraction of our seizures. But what we're going to do for all these seizures is good give supportive care, because we're going to prevent further harm. We're going to keep this patient from getting injured. Certainly, especially if we're coming upon these patients and we're off duty, we actually know what to do, and we can prevent these patients from having, helpful bystanders do unhelpful things. We can give them oxygen. We already talked about in the traumatic brain injury talk about how, sick and injured brain doesn't like hypoxia, so we can provide oxygen, supportive care for them. Get a good history and scene info. Do they have a history of seizure? Is this their first one? What medications are they on? And not just what are they on, but are any of those medications new? Or have they recently stopped any medications? Same thing with drugs. Not only what are they on, but is there anything they stopped doing recently? Could this be withdrawal? Very, very important history to get. And then trauma or medical issues that may be contributing to the seizure that we need to know about. If this is a post-traumatic seizure, then I want to really make sure that I'm not missing anything there. So when are we going to treat the patient? And we're really only going to treat the patient if they're in status epilepticus. And because our treatments all apply the brakes, we're giving GABA agonists. And so our benzodiazepines are GABA agonists, and the ones we have in the pre-hospital setting is midazolam, which is preferred, but also lorazepam and diazepam, or a barbiturate, which is it's an old school seizure medication, but it's something that we'll give for patients in status epilepticus in the ED where these other medications aren't working. So phenobarbital is our big one. And then just the general anti-epileptics of levetiracetam, I can't pronounce that, Keppra, or fosphenytoin, which is Dilantin. And here are the brand names for these two, just so you can have those in your head. So those are the different treatments that we're going to use. Again, Versed is going to be the drug that we're going to apply in the pre-hospital setting. But we only want to treat status epilepticus, and that's defined as a seizure lasting longer than 5 minutes. So if the patient has a seizure in front of you, start the timer, because I don't want to give Versed to that patient if that seizure is going to resolve spontaneously in less than 5 minutes. The other definition of status epilepticus that we treat is the patient has a seizure, they're confused and postictal, and before they return to normal mentation, they have an additional seizure. That one I would also treat. That's technically status epilepticus. Because once we have status epilepticus, that's a different treatment paradigm and workup paradigm in the emergency department. Generally, that patient's going to get admitted for status epilepticus and monitored. But a patient who has a single self-resolving seizure, the vast majority of those patients go home for outpatient follow-up. And certainly if they have epilepsy and they just had a seizure that's the same as their usual seizure and they wake up afterwards, they don't really need very much at all, and usually just the pre-hospital blood sugar and a good story and a good exam and the patient coming back to normal and saying this is just like all my other seizures. This is all I need. I don't need to scan these patients or do even labs on them or anything. We watch them till they're normal, and if they're doing good and it looks like everything's great, we send them home. And because generally they skipped a dose of their medication, so we'll give them an extra dose of Keppra or something like that and get them out. I'd like to do a quick public service announcement. Again, do not give the Versed if the seizure's over. If you drop the Versed, you're ready to give it, and the patient stops seizing, don't give it. Because it's helpful for me to see if the patient seizes again. It's helpful for me to see how long it takes them to return to their baseline. And it's helpful for me to see if that seizure looks like their previous seizures. Once we give a big dose of a benzodiazepine, the patient's going to be much more sedated. It's going to take longer for them to wake up. They may need some, airway management or further workup, or it increases my index of suspicion of bad stuff because I can't tell if it's the Versed or their disease process. They might get a more involved workup than they actually need. So if the patient stops seizing before you give the Versed, go ahead and waste the Versed, or keep it handy in case the patient has another seizure. But don't treat unless that patient is in status epilepticus. And if we're going to treat, here are the doses for midazolam for our ALS providers. We've got our adult pediatric, IV, IO, intranasal, or intramuscular. Intranasal is actually preferred. And so a bunch of different ways we can give this medication. If you have to give more than 2 doses, you got a contact base for that. And if we have drug shortages because the midazolam forests burned down again, we have also the dosing in Denver Metro for Ativan and Valium too, which aren't as preferred, but certainly can be effective in management of seizure. Also, make sure you're checking the blood sugar on these patients once you're doing all the other supportive care. It's helpful for me to rule out hypoglycemia. And the thing that you need to remember is that in good times, it takes me about 45 minutes to an hour to get back a laboratory blood sugar along with the electrolytes and the ED after the patient arrives. We haven't had good times for a long time because we've got staffing issues and flow issues in the hospitals with all the systemic stuff happening in the healthcare system. So if you can tell me the patient's got a good blood sugar because you checked it before you got there, that helps me out a lot because it's one thing I don't have to worry about while the patient's in there and I'm waiting for these labs to come back. It's also something I don't need to go find hands to go and check a blood sugar in the ED. So if it's something you guys are able to do, get that done as part of the protocol, and it's really helpful for me even when it's normal because it takes one bad thing off the list that I have to worry about when I'm dealing with a seizure patient in the ED. So very quick video on seizure, and again, focusing on the BLS approach, which the supportive care is really important, very much key. The treatments are also key, but also being very conservative with our treatments and staying in that lane of only treating the status epilepticus is key. That finishes our video series, or our long video on different neurologic issues. Thank you guys for all you do. If you have comments or feedback, my email's there. And otherwise, keep up the good work, and I hope to see you in person soon.